So good afternoon, everyone. Evening almost. Welcome to our guests, courageous people who flew over despite COVID-19. And thank you, Ilan, and thank you, the organizers of the conference, for the opportunity to lead a discussion that concerns the foundational issues of our field. The talks we heard today, the keynotes, as well as the research reports in the shorter presentations, provided a background, actually the rationale, for the choice of questions that will be discussed by the panel. In the course of the day, we have received an overview of where we are in our conceptualization of autism, or rather ASD. And it is against this background, and in particular, in view of what we just heard a while ago in Professor Happy's talk, that detailed the dramatic changes that have taken place in the concept of autism, that I will ask the panel to consider the need, if there is any, to move to a new mode of thinking about ASD. A recent review summarizing what we have learned in the years of research in the neuroscience of autism. Sorry, this should not have happened. A recent review summarizing what we've learned in 40 years of research in the neuroscience of autism provides the following as its summary statement. Many insights, no answers. This seems to be the state of affairs, not just in the neuroscience of autism, but in other areas of research in ASD as well. The major issues from the point of view of research are the non-reproducibility of results, the extraordinary heterogeneity of the populations that come under the label ASD, and the overlap between ASD and other diagnostic categories, most notably schizophrenia, ADHD, but also depression, cognitive impairment, language disorders. Now, what does it mean, no answers? Psychiatric categories are fuzzy and multifactorial, but this doesn't mean that we do not think of them as real, that is, as reflecting something in the world. Indeed, our diagnostic categories need to be useful and practical, answering to patients' needs, but we do expect them to be grounded in etiology, in development, and in mechanistic processes. Given this state of affairs, philosophers of science wondered what it means for psychiatric disorders to be real. There seems to be a consensus that while we are at a stage where we still do not have mechanistic explanations, the reality of psychiatric categories such as ASD is a function of how well it sits with the relevant scientific knowledge. Given this definition, having answers means finding pieces that fit with the general puzzle. Unfortunately, neurobiological, behavioral, developmental, as well as translational research have not produced so far a coherent story that confers a sense of reality on an entity that bears the label ASD. While voices calling attention to the state of affairs have multiplied in the last 2 to 3 years, the above conclusion is not new. It holds not only for ASD, but for other psychiatric diagnoses as well. More than a decade ago, when a new edition of the DSM was ongoing, there were people who were worried about the failure to map the proposed categories of what later became the new DSM-5 onto pathophysiology. A recent paper presenting the oral history of DSM-5 reports on the debate surrounding issues of what the author called the aspiration for a paradigm shift in DSM-5. Aspirations that unfortunately were not materialized in the final edition of DSM-5. Most relevant to reconceptualization of ASD is the recent evidence of a shared single common factor underlying vulnerability to diagnostically diverse developmental disorders and mental health problems. This factor, labeled the P factor and conceived of as analogous to G in intelligence, serves to explain the overlapping trajectory and symptomatology of mental illnesses. This is a relatively new, perhaps radical, idea that emphasizes the growing disquiet that the current diagnostic system arouses among researchers and clinicians. The P factor, in fact, captures what has been known in the field for a while now: the overlap in symptomatology within category heterogeneity, lack of category-specific developmental course, shared common and rare genetic gene mutations, and mixed neurobiological results point to diffuse boundaries, possibly non-existent boundaries, between neurodevelopmental disorders, among them ASD. The recent years have seen an increasing number of publications that call for a shift away from DSM-defined samples. This is a quote from Gilbert. With this idea in mind, the NIMH initiated more than 10 years ago its research domain criteria, hoping for more influence towards translational research than it has had so far. And I quote, "Our doc was motivated by the need to address the concern that the field had equated psychiatric illnesses with syndromes, and these syndromes are not well connected with neural or psychological mechanisms. The aim was, and still is, and I quote again, to have direct influence as the field moves towards personalized interventions and refined diagnostic categories." But let's focus on ASD. We hear more and more voices arguing that the dilemmas that the current definition of ASD have brought to the fore are not just the concern of neuroscience. Clinicians and behavioral researchers worry too, for this state of affairs directly affects the clinic as well. Understanding the causes and the mechanisms associated with ASD crucially affects the potential for early diagnosis before symptoms set in, as well as interventions and therapies. Just recently, based on 50 years of work on autism, Uta Frith had stated, and I quote, "It is an open question whether autism is a natural category." In other words, is the category ASD real? And one final note before turning to the panel. My entire introduction has not drawn a distinction between autism and ASD, reflecting the spirit of DSM-5. Yet questions about the reality of autism are not necessarily the same as questions about the categorical reality of ASD. We heard this afternoon how much has changed since the move from autism to ASD. Is it possible that something important has been lost on the way? So I call on the panel members, our guests from abroad, Swen, Diana. Yeah. So here's my question to the panel. In your opinion, in view of what we know today, is it time to give up the categorical status of ASD? Is it time to think of new ways of conceptualizing the developmental phenomena that are currently subsumed under this label? And perhaps to be more specific, how deep is our dissatisfaction with the current diagnostic status of ASD? Does it hinder research? How does it affect the clinic? Floor is yours.
Is this on? Okay. I don't think I can answer all of your questions, but I will take a little piece and then pass it on. One of the things I was speaking about earlier with somebody is when we think about the DSM or the ICD, we shouldn't lose sight of the fact that we're trying to address challenges that are causing impairment or causing dysfunction. And I think that there's an important question. We used to think of it one way, like in one direction. So a person who is autistic has these impairments and they need to adapt to the rest of the world. And I think that the Self-Advocacy Network has taught us that we should be thinking bidirectionally. So there are certain aspects that I do think it's valuable to help a person adapt. I think if you have no communication strategy that other people can understand, it will be limiting. It will cause impairment. But I also think that the world needs to adapt to multiple communication strategies, the same way that in many conferences, there are interpreters, there are translators, there's a person perhaps doing sign language. And it's trying to say to the rest of the world, we can be more welcoming and more flexible and meet you halfway. And so I don't think it makes sense to broaden the criteria so much that half the people out there are somewhere on this autism spectrum. If what we're trying to do is identify the challenges that would benefit from this bidirectional adaptation, I think it makes more sense to stop and think which aspects can we address through our research so that both the world and the autistic person can find somewhere to meet in the middle. And that's where I think we really want to not continue to expand and expand and expand. So I'll pass it to you.
Okay, I'm not sure what to add there. I'm completely the wrong person here, I feel, but just observing what's happened if we go a few years back and looking into the ICD scale where I'm working in research, there has been some changes, like Rett's disorder, for instance, has been lifted out of this, and Fradial X, and there are more and more very narrow subgroups who will be automatically lifted up because we will find an etiological reason, or even better, there is a kind of a treatment that necessitates and make this, we need this diagnostics. I think those parts are easy to see, and we will handle them automatically. And we should probably look at other kind of diseases. If we look in breast cancers in the 1980s, you published and said the risk of breast cancer is this and that, and the treatment is this and that. And nowadays you don't see that because you need to divide it in the ER positive and the PR positive, and everything is connected in a different way. And maybe we go there with autism as well when the treatment expands. I think that's just observational from me. And then method-wise, I totally agree that all analyses are facilitated if we can be, or if we can think that we are specific. So we are not including too much. So we know what we are aiming for and know what we are working to. And again, maybe looking at other disorders to get inspiration. Rheumatoid arthritis, for instance, it's also very diverse, joint pain, different kind of behaviors, and it's a long process to getting there. And so that might take, as a statistician, I need something which is specific. We're looking for etiology, so therefore the definition we come up with must serve that purpose. So looking at what we want to achieve and then go from there. Otherwise, it's always interesting to measure things and disentangle, but in the end, what shall we use it for? I think that's the most important.
Well, while we're talking about DSM-5, I should put my hand up and say that I was on the work group for neurodevelopmental disorders. It's a very interesting process I'm happy to talk about. But we were told very clearly that DSM-5 is for clinicians, not researchers. It's primarily for clinicians. And that was what lay behind collapsing social and communication aspects from the triad into one dimension, because the point was that if we ask a clinician to look for examples of social difficulties or good functioning, you can't look for social without communication. And if you look for whether you're doing okay in communication, you can't assess that without looking at it socially. So for a clinician, it was impossible to tear those apart. So that's why it went to a dyad, just as an illustration of the fact that it was primarily to serve clinicians. And I think, if we think about, are we ready for a paradigm shift? Who's ready for a paradigm shift? There's a research community, and that's, I guess, the focus here. But there's a general public. Awareness of autism in many places has really increased a lot, and I think for the good. It used to be when I started out that parents would say, I met a neighbour in the street, they said, aren't you lucky your child's artistic? So you hadn't heard of, autistic, they just thought it's artistic, good at art. So awareness has risen, albeit with some myths still, of course. What works for clinicians is another issue. What works for parents and families, and what works for self-advocates, and the identity that autistic people feel, all of these are different and all of these are important. I think Unita brought up a really important point, which is, are the challenges we're facing here special to autism? Or are they something that really is a problem across diagnosis, particularly across psychiatric diagnoses, where we don't typically have biomarkers we can reach for? And I'm put in mind of Temi Moffitt and Avshalom Caspi's work in the population-based Dunedin study, where they've tracked people from birth to age 46. And you see this extraordinary ebb and flow between different diagnoses. So it doesn't hold true that once you've had a depression diagnosis, you stick with depression. The younger you have a diagnosis of one of these common mental health conditions, they haven't looked at neurodevelopmental disorders in that study, but things like anxiety and depression, the earlier you have that, the more likely you are to continue in a diagnostic pathway. But it doesn't breed true. You go in and out of, not even just within internalizing or externalizing. It's not just anxiety, depression. It's all of the different diagnoses, including psychotic illnesses. All of that ebbs and flows. So there's a general issue about psychiatric diagnoses. And what I think would be helpful for us as autism researchers and clinicians would be, if there's an example, maybe Unita, if you look to an example where diagnosis is working well, or where the concept of a diagnostic grouping is working well, as an example that we could aspire to as autism researchers.
It's okay, I have. I think the question that I would like, perhaps we should focus on, perhaps we could separate the issues that concern the clinic versus research. Because researching the concept of autism, you have to abide by certain, methodological criteria, right? And if you're pleased with the way ASD and DSM-5 works, then the outcome with respect to the methodology of the research we're conducting based on this kind of diagnosis has not proven fruitful. I mean, it's not a question of, where we've had enough, let's change it. It just, we've had decades and decades of funds and very intelligent people and, social support and government support and everything. And there has not been progress. I mean, progress, yes, in the sense of insights, but no clear answers, right? There have been no, and this primarily affects the clinic, right? Ultimately affects the clinic. So the question really is, as far as I'm concerned, is maybe we should, think of other ways of doing research, right? I'm not, and there have been some proposals recently of how one could proceed, right? So, you want half the population to be diagnosed. The way it's rising, who knows where it's going to go? Annie, לא שמעת. What did he say?
I mean, I think the work that you talked about today shows that we are progressing.
So it depends on what you're calling progress, right? So my work is not trying to understand the causal mechanisms. And I do think that's an important area of research, but I worry that we haven't learned enough to really make a difference in terms of understanding etiology. But I do see a lot of progress on better understanding some of the strengths that balance the challenges and understanding how early intervention can completely alter the trajectory for a child who has the opportunity to have focused learning for areas that other children are going to pick up incidentally. And I think there have been quite a few gains in understanding what some of those active ingredients are in early intervention, because for probably a couple decades, one person made a manual, they collected their data, they published it, they were the only ones who knew how to do it, and they didn't talk to the person in a different lab who made a different manual and said, mine is very different, you have to do it my way, this is the one. Well, it turns out there isn't only one way to help children learn how to communicate and support their social engagement. And while I don't think that our goal is to cure autism or eradicate autism, I think our goal is to support the development so that people can communicate and engage with one another. And it turns out that finally, not only I think 8 or 9 years ago, all of these different inventors of these interventions got together and said, we have more in common than different. And they published that paper on NDBIs, right? Naturalistic developmental behavioral interventions. And it turns out that all of these different manuals are different flavors of very, very similar approaches, and they have similar outcomes. But even after that paper, most folks still ascribe to one manual and only studied it one way. And a collaborator in my research program, Dr. Giacomo Vivanti, was the first person who convinced 12 of these researchers to pool their data so that he could look at not does this treatment work this percent or does that treatment. He wanted to look at when children are exposed to intensive evidence-based intervention, they make different amounts of gains. And what can we do to better understand why some children make more gains and learn spoken language, learn play skills, and other children continue to struggle because probably those children need something to supplement that NDBI. And if we could better understand who's in which group, maybe we can start to figure out what are those supplemental treatments. And I think it's really important because for a long time, everybody put up their walls and they wanted to do their own thing their own way, and that limits science. And so for me, I think we can make more progress if we develop these collaborations. So when people pull data like the new database that you're creating here or the data in the Nordic countries, that's where I think we have the best chance of really starting to learn more. And my emphasis is always on the research that's going to really make a difference in the world. And so I'm very interested in the kinds of advancements that will impact the lives of autistic people and their families very quickly, not 10, 20, 50 years down the road. So I really do think that there are a lot of positive gains, but probably not in the way you're thinking about genes or brain mechanisms, but in some of these more real world applications.
The point is gene and brain mechanisms are eventually going to help people. I mean, it's not because it's an interesting problem. That's not the motivation. Motivation, sure, it's an interesting problem, but that's not the motivation. Motivation is to be able to diagnose early, to have an understanding of the mechanism and perhaps find better ways of, affecting the outcome, right? So, I mean, we're in the same boat.
And I don't disagree with that. And I think that we also want to understand the brain better. And we are very early in understanding the brain. But I'm not sure during, my lifetime we'll suddenly figure out the brain. People have been trying and trying and trying. And for a little while, I was a neuroimaging researcher. I don't know if you know this, but I spent a couple of years focusing in my postdoctoral fellowship on fMRI because I thought this was going to be the thing that really answered all of our questions. And I got disenchanted because about every 2-3 years, people said, okay, I understand. We made this mistake. It wasn't this kind of measurement that we need to do. It's this new thing. And now we're going to answer all the questions. And so I remember a couple of them. First we were doing these block design studies that were so clunky because we had to do groupings. And when we learned to do event-related, that was going to change everything. And then it was, okay, not just task-dependent activations. Now we need to study resting state. And then it was, nope, we're making a mistake with all this activation stuff. It's the white matter. They might all come together and answer questions, but for that, we probably really do need this transdiagnostic understanding of how the brain develops and how it changes. But I'm not sure how and when that's going to make a difference. I think just to learn about it is great. Sometimes we can be excited about science just for the sake of science. But if you want your science to really make the difference, you have to then draw the connections to what happens in the real world. And that's where I worry that the folks who are doing the most careful looking at the brain don't really know what it is that they're studying in the real world. And we lose something, I think, when people silo off in the lab and haven't seen what a person living with autism might be experiencing. But I don't want to monopolize.
So I agree. I mean, I think it depends on the level of description you're interested in. So you said that, if we knew the genes, if we knew the brain, then we might be able to help. But I do look to, for example, Down syndrome, where we've known the cause for a long time. Has that helped people with Down syndrome? I don't think it's helped people with Down syndrome. I think we know more about how to accommodate and teach well to the thinking style of autistic people than those with Down syndrome, because that discovery went down a completely different route. And a group that we've worked with a little bit is individuals who have no corpus callosum. And the parents there will say, I take my scan in to the teacher to say to her, look, the reason my child is really struggling in your class and struggling with maths is they don't have a corpus callosum. And the teacher says, nice scan, I don't know what to do with that. If you tell me they're autistic, I know what to do with that. So we do have some ideas about prognosis. We do have some ideas about what works well with many autistic people. I think we have made progress. It may not be the mechanistic progress. And certainly from my idealistic days, it would have been, from my point of view, great to have a cognitive characteristic of autism that was universal. You could say, okay, like a kind of perfect notion of a dyslexia test. Even if you can read now and spell now, let me test your rapid naming or something, and I can see you're actually still autistic. You can declare conflict of interest there too. I'm autistic. I'm dyslexic. So, having those markers would be great, and it's disappointing we haven't found them. But am I uncomfortable with heterogeneity? Not that uncomfortable, because if I think about the heterogeneity I'm very comfortable with, I've seen, so Professor Michael Rutter used to have the office next to me, who did the first twin studies. He diagnosed the son of a woman I got to know very well. So this young man was prototypically autistic as a young child, and if you met him now, you wouldn't recognize his autism unless you spent a considerable amount of time with him, or he was very, very tired or stressed. Great heterogeneity. Over his lifetime, he has shown enormous heterogeneity. I met autistic women who, when I first met them, they told me they were autistic. I don't doubt them, but I thought, I can't see anything. And then I met them again when they were tired or stressed, or I had them come to stay, and I could see the autism. Massive heterogeneity over a smaller time scale. So I'm not troubled by that. I believe it's the same person with the same cognitive style. It looks different. The world's messy. I'm okay with that. But I agree that we don't want to stretch the spectrum so far that it's meaningless. And then I think, that depends how we do that and where the reason that Asperger's syndrome was folded into the autism spectrum was that everyone said they could recognize it, but actually when the research was done, it wasn't any characteristic of the individual that determined whether you got the Asperger diagnosis or an autistic diagnosis. It was what clinic you went to. So there are ways to do the research to find out, are we on fairly solid ground or not, I think. But I might just be a bit optimistic.
So with the DSM-5, are you missing the classification from DSM-4, or is it working?
I'm not a clinician, so we'd have to ask the audience. We should maybe ask the audience their views on things.
Changes expected there.
Yeah, I don't know what those are. I wasn't in there. Should we ask the audience?
There was this recommendation for a separate profound autism classification. That was recently clarified by experts. I don't know if that's it. I mean, it's been declared that there's going to be a change in ASD diagnosis in DSM-5 text revision. And I'm just associating it with it too, but that might be one direction, which again splits it. I wanted to ask a different question. You gave a very good example earlier about NDBIs and how when people stopped saying, this is my way and the other is different, and started looking at commonalities, it actually opened up a lot of new opportunities. Similarly, if we, aren't we hiding behind our diagnosis saying, no, this is autism, that's not, which is why this intervention would work only for autism, not for other things. When knowing that there are so many different comorbidities, we're actually limiting our ability to support different individuals with neurodevelopmental conditions. So maybe an alternative would be, it's still a dirty alternative, it's very broad, would be neurodevelopmental disorder. Then when you classify the kind of support each person needs, you'd need these dimensions. Looking at, okay, so the communication difficulties, flexibility, emotion regulation, attention.
Well, I can comment a little, thanks. So I think that if there are overlapping characteristics and you're trying to address that particular kind of characteristic, so communication as an example, then perhaps one intervention will work for children who have communication challenges with different diagnostic labels. But if the quality of those communication challenges is so different from one diagnostic group to another, it's unlikely that the same treatment will work. So I think you have to figure out how to measure the quality of the challenges first. But I'll tell you, we actually asked this question about Down syndrome because we were starting this big clinical trial in autism, and the NIH put out a call for supplements where the studies are not focused on Down syndrome, but could add a Down syndrome piece. And we thought, you know what? Nobody is really asking how children with Down syndrome can be supported in their early learning. What if the Early Start Denver model, one of these manualized interventions that's been created for autism, helps children with Down syndrome learn more than the usual community intervention, which is sort of a mishmash of some speech therapy and some occupational therapy and some what they call developmental therapy, but I can't find a definition of what that is. What if using ESDM really helped with the communication challenges in Down syndrome? So we got this extra award, and we started to recruit children with Down syndrome, and then COVID happened. And it turns out that many children with Down syndrome have serious health conditions that put them at very high risk for poor outcomes from viruses like COVID. And so we had aimed to recruit 40 children, and I think we just passed 10 or maybe 12, and the project is ending in a couple months. So I don't know if we'll have enough data to answer this question because COVID really interfered with that piece of the study. But I do think it's a question that's important to ask because folks I think maybe made an assumption that because Down syndrome is a known genetic condition, there's nothing malleable about it. And that seems foolish to assume that just because you found this gene, that means it's fated and there are going to be these serious limits. Perhaps investigating different ways of teaching will open the door. But it may also be that children with Down syndrome need a different teaching style, and that ESDM will need to be adapted to better suit children with Down syndrome. And it actually, there's a new version of ESDM where children are brought together in small groups. And we were really hoping to test that because kids with Down syndrome are very socially interested. And perhaps bringing them together with their peers would really facilitate their learning. But again, during COVID, not a single family would sign up for our small group free intervention, 6 months of 10 to 15 hours a week in a little classroom we were going to create, but nobody wanted to bring their kids to a room with other people. And so I think we'll just have to wait and do that study again when children are vaccinated and, little ones are vaccinated and parents are ready to bring their kids in, because I think these are important questions.
Why don't you add Williams syndrome to it?
I would love to. Do you know somebody who wants to fund that?
Sure.
Absolutely. I would love
all of the
to.
Israeli Williams syndrome children. There aren't that many, but
It's the same thing. Don't make an assumption that because there's a known etiology that the outcomes cannot be influenced
my
with it.
experience with children with genetic disorders has not been similar to what you said. It's not been the assumption that because there's a gene identified there, you can't do anything. I mean, that's clearly not the case. I mean, these children benefit from intervention and make progress and look different.
But there's not
in
the
way
same
they
attention
were.
to measuring it, I think, in the literature.
Yeah, of course there is. Yes.
I think that when you talk about genetic disorders, it becomes very, very specific. And then there is a lot of very amazing literature about the endophenotypes that if you look at the VCF, if you look at Williams, there are specific characteristics that we learn from them a lot that we can learn to other syndromes that are less needed to understand, less the genetic way of thinking. I think that about Down, for me, what bothers me, mentioned, there's very different Down syndrome patients. Some of them are autistic, like DSM-5, and some of them are very socially interested. So I think that when we talk about Down syndrome, as opposed to, I would say, Williams, that is not that heterogeneous.
And the Williams syndrome, there are Williams syndrome plus autism also exists. But then, everything plus autism exists. I don't think there's a single syndrome in which you can find autistic as well, which raises the question,
I only
what
wanted
is autism?
I only wanted to make the point that knowing the genetic basis doesn't let you understand the condition in a meaningful way at all the different levels that
Of course
matter.
not. Of
So,
course
we need to think, what are we doing the research for?
Right.
You know.
What is it for?
Can I
Could-
ask and comment?
You do have specific treatment.
Ma'am?
If
I'm-
you have the Hunter syndrome, then you have a specific treatment. I mean, like when I think Professor Davis has studied a lot of fragile eyes and fragility,
Miss-
there are specific treatments for specific genetic problems.
Oh.
So there is a big issue of learning that.
Doctor?
I was just trying to say that I think many clinicians are sharing this disappointment from fighting the biological origins, the genetic origins that are specific for autism and for other psychiatric disorders. So one way to look at it, it's okay, let's just put in the DSM-5 whatever we know the exact biological mechanism. I don't think that will lead us to a better approach for treating or helping the kids or the adults with autism. And the fact that we don't know the exact mechanism of ADHD, anxiety, schizophrenia, or autism doesn't mean it doesn't exist, because I think there is enough knowledge, I would say, that ASD exists. I mean, maybe you are trying to make
No,
us
I'll be
think about
happy
it.
to hear it.
And I think that the diagnosis for now is helping us to characterize specific group of children and people that need specific help, and we need to make it more maybe accurate and more comprehensive and more wide, and to know all the comorbidities to really help in a specific way. My wish with research is not, our mind goes to the biological aspects. We're really curious about understanding it. And if you look about research resources of the NIH, you'll see many more grants about functional MRI and genetics than interventional.
It's more expensive.
Yeah, so my wish with research, it's not looking for another gene or another anatomical abnormality, but putting more research into screening and interventional models in order to understand what helps better for which child or person.
May I also have a comment?
Sure.
We want to open this for, first we need a microphone for the audience, I think, because I assume half of you didn't hear. Are the people in the back hearing what's happening in the front? Not so much.
יואב מגיע לו אחרי היום, אחרי הצהריים.
I have one comment. Either stand up and talk loudly or. I'm a little bit discouraged about the pessimism I hear here about science, and I want to be I'm a little bit more optimistic, or maybe you'll say naive. But I think for many years, cancer was treated only by chemotherapy, and this is because and the major cause was understood, but a deeper understanding came from genetics. And once people started to understand the different types of cancer and the different these different subtypes of cancer, they started to study different and develop new therapies. And like Diana mentioned in her talk, science moved very, very slowly. Once after you make any findings, once you are developing a treatment to treat a certain cause may last for more than 20 years. So I believe that the fate of autism, or at least some of the people of autism, they will benefit a lot from science. I'm also disappointed about the success of scientific studies in the last couple of years, that the achievement that the change they made for people with autism, but I'm more optimistic about the change that we can do for people with autism for the next 20 or 30 years.
Thank you. I think there's a...
צריכים לבוא לפה כי זה...
Just wanted to open the discussion to another direction. Maybe not looking at ASD as a whole concept or syndrome, but maybe we should look specifically at the behavioral construct in the DSM or beyond the DSM, and look at the same characteristics genetically or in other ways, or by the effect of treatment, but looking at social problems, or looking at, because those characteristics occur in many syndromes and in the general population as well. Some it may affect functioning and some not. A lot of kids have problems with restriction, with wanting things to be the same. So maybe it has some genetic origin, or I don't know, neurodevelopmental origin, and maybe we should split all the traits and study them, separately, not collectively. And maybe then we will find, more accurate answers in terms of research, not in terms of clinical intervention. Or also look at what is helpful to some of these deficits and look back and see if it has any neurodevelopmental or genetic or other origin. What do you think?
You may remember who was the person in the original history of psychiatric diagnosis who said there were people who were splitters and there are lumpers, right? And I think what DSM-5 has done for autism, for autism right now, is being a lumper, sort of collecting more people, which creates a situation in the clinic that I've heard. I'm not a clinician, but I've heard many people, I think including Rita, who talk about their difficulties in diagnosing children, their sort of uncertainty, there's sort of like what Yoav spoke today, sort of I'm not that sure, and really agonize over these things about what should be the diagnosis of this person. So maybe this has gone too far. Maybe, and this is what I was alluding in my last sentence in this thing, is maybe autism and DSM or ASD is not the same. So maybe there is, maybe it would be justifiable to talk about autism, but ASD has done something that is sort of brought into the community people, and this has nothing to do with the effective intervention, I think, because intervention probably will help the Williams syndrome kids that you will have in your group, because that's the syndrome I know best, and it may have helped them. But if we think about the autism, the classical one maybe, Kanner type, or further, perhaps it'll start looking better.
Let me just say one thing, because I've heard it 2 times already. I worry very much that we should make a separation in how people do research and what happens clinically. Because if we separate them and say we should do research separately from how people are going to actually work with families, work with children, adults in the community, our research becomes useless because nobody will know how to apply it. And the point of the research is eventually to have application.
Right.
Even the most basic science question should have maybe 20 or 50 steps down the road an application that matters.
Right, but then
So-
that's a different question then. I think that's a very serious question, but it's a question about how do we communicate, what are we going to do? It's not a question of what would be a good way of doing it. Now the question becomes, how do we establish a relationship? How do we communicate? How do we transfer knowledge from one to the other? How do we cooperate? But that, I agree. This is probably a very, one of the main questions why the situation is the way it is.
This gentleman had a question or comment.
Thank you. So there was a question whether we miss DSM-4 by Professor Sandin, right? I miss DSM-3R because then life was much simpler. And I know that Professor Happe heard my talk. I'm very honored about overdiagnosis. It's true that we, in psychiatrists, clinicians, psychiatrists, we don't like to have disorders with a clear etiology. If we find a gene for a disorder like Rett syndrome, we take it out of the DSM. We like things that are more complex and blurred, but we still have to be practical as Professor Robin says, and treat people who come to us with problems. And if we keep on broadening the phenotype and letting everyone go inside, so I heard, I wasn't here yesterday, but I heard that there is a talk among the community that autism is not a medical diagnosis, that everyone who feels that they're autistic can be called autistic. So we're going into a social realm. We're leaving the medical, psychological, clinical realm. We're talking with the social phenomena. And I think we have to put a break on it. So I would be very happy to hear all of you, and especially whoever heard my talk about overdiagnosis, about what you think about that issue. So.
So when we proposed folding Asperger's syndrome into the autism spectrum, there were various complaints, including some people saying, but Asperger's syndrome isn't stigmatized and autism is, so you should let us keep our Asperger identity. And while I mean, the point was always anyone can keep the Asperger identity, it's just that to make it a separate diagnosis, you need certain kinds of evidence that it's separate. But the point that one thing is stigmatized and the other isn't, so we should keep the unstigmatized one, is a terrible point, because we should be unstigmatizing autism. And I think we have unstigmatized autism. Part of the reason that so many people come for diagnosis is it's lost its stigma. We should celebrate that. We don't want the diagnosis to be meaningless. If it doesn't replicate between different clinicians, then obviously something's gone wrong. And there are some clinical centres that I know in the UK where everybody, adult centres, everybody who goes through the door comes out with an autism diagnosis. That can't be right. It just isn't plausible, because we know that lots of things can be question mark autism, quite understandably. So clearly there are some problems, but I think that's a question about sort of diagnostic validity. Things like polygenic scores may help us with that a bit in the future. Everybody thinks a biomarker would be great. We haven't made any progress towards one as far as I know. Whether there are examples in other cases, I don't know. But you look at something like ADHD, which is a really interesting parallel, lots of parallels, underdiagnosis in women and girls, a widening spectrum of recognition that, well, maybe it's often just inattentive, it's often somewhat silent, it's compensated for, and so on. And then you have this enormous difference that you have a medical treatment for ADHD that actually works on core elements, but you still have lots of questions. So the suggestion that there may be late emerging ADHD, genuinely late emerging, not previously camouflaged, late emerging ADHD, and is that the same thing or not? And again, I think we can point to that and see that there have been good, sensible approaches. Is the neuropsychiatry the same? Are the cognitive markers the same? Is the prognosis the same? We can ask these questions to see what we should put in the same category and what should be outside the category. I don't actually think that I wouldn't particularly defend DSM-5, but I'm not sure there's anything in the criteria that has made it enormously wider. I mean, when we put in Asperger's syndrome, it wasn't me, when Asperger's syndrome went in, that widened things, because suddenly we had this concept that you didn't have to have language delay. But I'm not sure that, at the time of DSM-5, people actually said, people are going to lose their diagnosis. This is going to get narrower. So I think we have to separate that out from a time trend in awareness and in the conceptualization of autism that says this isn't something to be frightened of or to be ashamed of, and you can go and seek services. And also a time trend that in many countries, lobbying has meant that the services for autistic children are just better than the lobbying for other groups, which is unfair. We should be bringing the other services up to the same standard. But I'm not sure that it's all about diagnostic criteria, although I'm really happy to think about the concept of autism outside diagnostic criteria, because the diagnostic criteria clearly have the element of impairment, rightly or wrongly. And people say, well, why is autism in DSM-5? It's a diagnostic statistical and mental disorders. It's not a mental disorder. Absolutely fair enough. Autism in itself, we can say, is not a a mental disorder, I'd agree with that. But to get an ASD diagnosis, you have to meet an impairment criterion. It has to be impairing your life to a significant degree. And so I think we need terminology around what is autism when it's not autistic spectrum disorder. So is it autistic personality type? Is it autistic neurotype? Is it, no, we have to think about autism that's outside the diagnostic system, I think. And I think that would help in terms of, the kind of flood of overdiagnosis. It's this magnet that draws people to it. And rightly, you can identify that you have many characteristics that make you feel that you're part of that spectrum, but you don't necessarily need a diagnosis because you may not be impaired by that. I mean, please God, if we could get accommodations right, nobody would be impaired by it. So anyway, that's I've said too much already. There's somebody here wants to ask a question.
So I think what you just said is a new way of conceptualizing ASD, right? I mean, this is a new way of thinking about it, right? So,
we also have to, I know I'm hungry, and I don't know what about you. And we already have dinner served in another building a few steps away. So you want to maybe three more minutes, and then we'll head off. Is that okay with everyone? So, I don't know, who goes first?
I'm a clinician, and first of all, the changes which have been what?
Take it off.
I'm a clinician, and the changes that have happened in the last few years are very positive, I'm sorry, are very important, and we are going into a very positive era. I mean, and this is something very important to say. People were speaking about pessimistic. It's exactly the opposite. We're getting more and more ways to treat and more patients that we can treat them. So it's a very positive time. Now, the DSM does have problems. I really don't like the DSM. I mean, because it doesn't do the work. I see so many patients that I can help them as a physician, and they don't have the B of the DSM. So I know that this patient is autistic, but I can't give him the diagnosis because it doesn't have B. Or he may have one of the A's, one of the social problems is very severe, but he doesn't have the other ones. So the whole classification into a diagnosis is something which I think, as a concept, is not the right thing for autism. It was good for infectious diseases like pneumonia or things like that. And what Dita was saying was right. We have to break it into functions and say this function is working, this function is not working, this function. And actually, just like in the motor system, we have like, 100 or 200 muscles. Here, the same thing. We have 100 functions, and we can say this function is working, this one is not, this one we can treat, and this one is not, and we'll make the treatment directed at that specific function. Dita was saying that, right? And I think this is the change that the DSM has to go to. Instead of one diagnosis which would fit, it's better for statistics. I apologize, but it doesn't fit our clinical needs. And I think that's the change that has to go.
But then it's not a diagnosis, right?
What?
Then it's not a diagnosis. I mean, motor impairment is not a diagnosis.
You can have a package saying, yeah, that seems like a communication
blood
problem.
pressure is not a diagnosis, right? It could come, the origin.
It could come from various reasons. It could come with Down syndrome,
Right.
whatever.
So,
and then we know what we're treating, we know what we're diagnosing, and it would fit our clinical need more.
Wow, we have a challenge between the two HMOs.
I'll keep it brief because you already said it. So thank you for your last remark. I wanted to emphasize that for me as a clinician, I think the most important criteria in the DSM is impaired function. So we're talking a lot about symptoms and the blurred symptoms between typical and atypical features, but we need to prove that there is impaired function that we're trying to improve. And the other emphasis that I wanted to make, my talk was by being a splitter and discussing the individual differences. but we lump together the shared features and the phenotype, and we tend to split, and it's important to know that, the etiology. And we need to have a very definite designation when we talk about etiology, like when we can discuss Rett syndrome or Fragile X, and all those are reasons for different symptoms, that some of the symptoms can meet the DSM criteria for autism or for intellectual disability. That's another very, very complex issue about the blurred vision, the blurred boundaries between intellectual disabilities, autism, and shared features between them. So we should talk about symptomatology, and I think it's important to know etiologies, prematurity, genetics, any other etiologies, and not always all our knowledge is influencing the intervention. Some of it does, some of it may take us to other paths of interventions that are genetically driven, or driven by etiology, or driven by the symptoms. So.
Okay, thank you. I try to be short, but I think one of the most appealing ideas that I heard, I think it was Professor Simon Bauer-Cohen in one of the INSAR conventions. He was talking about developing, I think it was him, developing communication social quotient, the same way that we have an intelligence quotient and an emotional quotient, and maybe if we have a Gaussian distribution of those characteristics that we know that we found in normal population, we know that people in the family of people with autism have all kinds of autistic features, and we see that, and we know that from our own everyday experience, people that we meet. And if we have this kind of distribution, and we can create a -2 SD that we can determine as the cutoff point from under which, if you got that certain score, you will be determined as autistic or borderline autistic features, or whatever the scientific committee would decide to call it, and then we'd have something that we can more definitely call autism, and not be in this like walking in a cloud that we feel sometimes as a clinicians that we have to rely on our gut feeling, or because the DSM criteria are also some, to a certain point, subjective, and it's your own decision as a clinician. When do you decide that you give this certain criteria or not? And I think many of the discussions and the conflicts that we have here are because we do not agree where we put the cutoff. But if we do have a number, and I know it's arbitrary, and it has to be relied on lots of research that wasn't done yet, but I think it can be a solution.
Thanks, Dorit. Okay, Sola, you will end this conversation. You'll be the last one. Do you want the microphone, or do you want to come up?
Neither.
I have one short sentence. Oh, okay. I'm asking. I'm asking, I'm autistic. I have one sentence to answer all of you. I think that some of the answers are within the autistic community. Work with us to find the answers. I don't have time to detail the answer, okay?
Okay.